morning, everybody. Welcome. Thanks for coming. So we'll get started. So it's our pleasure today to have one of our own, Dr. Ryan Ungaro here. He's an assistant professor in the Division of Gastroenterology. Dr. Ungaro completed med school, residency, and fellowship all here at Mount Sinai. He was chief resident and chief gastroenterology fellow. He received training in IBD research as a Howard Hughes Medical Institute research fellow, and also completed a master's of biostatistics and clinical research methods at Columbia. So now he specializes in care of patients with ulcerative colitis and Crohn's disease, and is director of the comprehensive care of the recently diagnosed IBD patient program here at Mount Sinai. And his research focuses on the early intervention in IBD. So we're very glad to have you today. Thank you.
Thanks for inviting me. It's fun to see so many familiar faces. Actually, my first research experience was with Alex many years. Well, not that many years ago. I guess many years ago. Your kid's going to college now. Yeah. So yeah, thanks for inviting me. And it's exciting to be here. So I'm going to talk today a little bit about a topic that's of great interest for me clinically and from a research perspective, which is early intervention, risk stratification of IBD patients, and delivering the most effective therapies early in the disease course to really try to modify the course of disease for patients. And I'm going to first, though, since I'm not sure how familiar, we're at Sinai, but how familiar people are with IBD, just to give start with a little refresher of some IBD topics, overview before jumping into the more specific things. So these are my disclosures. Basically, most of the medications that are used to treat IBD, I've just done either advisory board or research with, like most of the people in IBD. It's kind of so, like I said, I'm going to be refresher. Then I'll talk about IBD, how we've now changed the concept of it as something from episodic to a more progressive disease. Why is early intervention important? What are some of the data supporting that? And then what are some of the obstacles that we have that impede us from providing effective early care for patients? And then I'll talk a little about our program here, COMPASS-IBD program, which is a program, multidisciplinary program at the IBD Center that I help run for recently diagnosed patients. So first, I think for any IBD talk about Sinai, I always like to start with just a quick historical perspective, because I always like to say that it feels like a real honor and privilege to be doing IBD at Mount Sinai, because it's standing in the footsteps of giants here. So basically, Crohn's disease obviously was first described here in 1932. This is Dr. Crohn here. Anybody know who the other two people are? I wish it was Jared. Yeah, not sure. So Dr. Oppenheimer and Dr. Ginsberg, who are actually a pathologist and a surgeon, and legend has it the two of them did more of the work discovering and describing Crohn's disease than Dr. Crohn did. But at the time, the way papers were published was alphabetical. So it could have easily been Oppenheimer or Ginsberg disease, but instead we have Crohn's disease. And in meetings, apparently, Dr. Crohn used to refer to Dr. Ginsberg and Oppenheimer as et al. So, so that was that's like a little IBD kind of zinger there. See, we actually have a lecture, Oppenheimer-Ginsberg lectureship to still honor their contributions. Lots of surgical techniques, recognition that IBD is associated with cancer and how to best survey, where the pioneering work was done here. And basically every single medication in IBD over the years has been in some way studied here or pioneered here. And two of the legends recently I had the privilege of knowing were Dan President, who passed away, was a private practice actually, but an academic doing lots of work, especially with biohearings. And Tanessa Wood there, was the former head of GI here, as a legendary translational researcher and was involved in advancing the field. So I always like to start with that. So brief IBD refresher. So what is IBD from a global, high 10,000-foot view? It's a chronic disease of the digestive system, the way that rheumatoid arthritis or lupus is a chronic inflammatory disease. These are chronic inflammatory diseases of the gastrointestinal tract. And there are two flavors, Crohn's disease and ulcerative colitis, which you're familiar with. Crohn's disease can affect anywhere from the mouth to the anus, and ulcerative colitis affects principally just the colon alone. So when you look at how these diseases are distributed in the digestive system, in Crohn's disease, the most common location is the terminal ileum and the cecum. The vast majority of patients will have some combination of these two involved, and we usually refer to this as ileocolitis. The second most common is ileitis alone, and the third most common presentation is colitis alone. So this is sometimes where you see patients where they say they have colitis, we're not sure if it's Crohn's or UC, and sometimes we fool a little bit because Crohn's itself can present as just colitis as well. It's only about 20% of the time. It also can affect the stomach and upper digestive system in about 5% of cases, and those are notoriously difficult to treat. And in contrast, ulcerative colitis only affects the colon and has three major phenotypes. Proctitis, where it just affects the rectum, left-sided colitis, where it only goes up to the splenic flexure, and then pancolitis. This has implications for how we treat patients and how they present clinically as well. So for example, when the rectum alone is involved, due to proctitis, the primary symptom we see is urgency and tenesmus, kind of dry heaves of the colon. And whereas when you have more pancolitis, you have more systemic symptoms, fevers, chills, abdominal pain, etc. So IBD is actually fairly common and rising in incidence, and it's estimated now in the United States up to 3 million people have IBD, most commonly affecting people kind of at the peak of their lifespan in the 20s to 40s, when you're most productive and you're going out starting a family. And so it's really kind of, it's unfortunate that it usually afflicts young people right at the prime of their lives. And in Europe, Canada, and the United States are where the highest prevalence rates are for both ulcerative colitis and Crohn's disease. I'll show you in a second that these rates are rising throughout the world. And these diseases are incredibly expensive. There's $8 to $15 billion per year in indirect and direct costs spent in the United States alone on IBD. A lot of this is due to lost work productivity. This is a study from Norway where they looked at Crohn's disease patients who were twice as likely to not be able to work if you had a disability compared to the general population. And when you look at the distribution of costs, Crohn's disease tends to be more expensive than ulcerative colitis. This is from a study from the Netherlands, so probably the United States kind of come out to here. And when you look at where that money is being spent, the majority is on lost work productivity, but a lot is on our newer medications, biologics, which are very expensive. There's now new medications, they're not generics, but I use that term in quotes, generics of biologics now available called biosimilars. So right now for infliximab, which is the IV anti-TNF medication, that is now out of the market and should be driving down costs. So these therapies should become more affordable in the coming years. And then the other major costs are associated with hospitalizations and surgeries. And these costs are likely to continue to increase and are increasing worldwide because the incidence of these diseases has been going up ever since they were first described. So in the red, this is the rate of the prevalence of IBD in the Western world, where the first case of colitis was described back in the 1850s. Crohn's disease around here, and it's been going up and up and up ever since. But what's a new phenomenon is that if you look at developing countries, in particular China and in India, the rates of IBD are escalating as well. Probably due to the fact that these countries are becoming more and more westernized, looking more and more like the United States, more McDonald's, etc. Whatever you want to ascribe the rising rates to. What this points to is that environmental factors play a key role. And so what causes IBD? The short answer is we don't really know, but we think it's an intersection of three things. One is the environmental triggers I just mentioned. I'll come back to in a second. There's definitely genetics involved, with over 200 genes associated. There's not one specific gene, so it's a complex genetic disorder where you have to have some complement of genetics mutations that predispose your immune system to then becoming dysregulated. So your immune system is dysregulated. It's in the on switch permanently, not able to regulate itself, and turn off switch. And this is all in the setting of environmental triggers. What that is, there's been lots of things associated: smoking, antibiotics, certain surgeries, air pollution, things in our diet, all go along with westernizing modern society. So how do these diseases present? So the symptoms of IBD you're probably familiar with in general because they look a lot like a lot of other GI disorders. So that's what makes it sometimes challenging. Diarrhea, increased frequency of bowel movements, abdominal pain, cramping, decreased appetite, fatigue, and rectal bleeding. So rectal bleeding obviously is a red flag for us, and for you guys as well, where these things are more likely to get worked up much more quickly. But all these other symptoms can be very vague. It can be chalked up to food poisoning, IBS, lactose intolerance. There's a lot of overlap here, so it makes it sometimes diagnostically challenging. In general, when we see bleeding, we think more ulcerative colitis. When we see diarrhea and abdominal pain, we think more Crohn's disease. So when someone comes to me saying they have colitis and they've never had rectal bleeding, I'm thinking maybe it's more of Crohn's colitis, for example. Whereas someone's coming with a lot of urgency and bleeding, I'm thinking more ulcerative colitis. But based on where the disease is located and how much is affected, and how much the digestive system is affected, these symptoms can vary. So if you have more systemic symptoms, that's more of a pancolitis picture or more extensive disease, whereas if you're having more just rectal urgency and tenesmus, that's more localized. And what does these diseases look like on endoscopy when we're doing a diagnostic colonoscopy? The classic features are these long, serpiginous, deep ulcerations in the ileum or in the colon. This is the classic aphthous ulceration, which is a shallow ulceration with a red halo around it. And you can get other things like fistula, which are connections between bowel and bowel, or bowel and adjacent organs, and also strictures as well, narrowings in the bowel. Ulcerative colitis, in contrast, you tend to not see those narrowings, fistula, or deep ulcerations, except in very, very severe cases. It's more this continuous, friable erythematous, edematous, with some shallower ulcerations that go continuously from the rectum proximal. So when we see colitis that's very patchy, we think maybe it's more Crohn's. But invariably, in ulcerative colitis, the rectum is involved. So if the rectum's not involved, we start to think it's maybe more Crohn's than ulcerative colitis. So diagnosis of IBD, not to belabor this too much, but there's not really one clear blood test or biopsy finding that says this is IBD. It's really a conglomeration of the history, imaging findings, endoscopy findings, pathology, and blood work. The most important thing is on endoscopy with a biopsy, having findings of chronic inflammation on the biopsy. So lots of lymphocytic infiltrate, plasmablast infiltration. That is really the hallmark for histologically. For Crohn's disease, you have granuloma, and that's interesting. But even in Crohn's disease, only 30% of cases of confirmed Crohn's have granuloma. So if you don't see granuloma, it doesn't mean it's not Crohn's disease, but it's certainly very helpful when you find that. And this is just a laundry list of things that are in a differential diagnosis, some including functional. But the major thing we're looking to rule out when we're looking at a patient with IBD or suspected IBD are infections and other inflammatory conditions, either related to ischemia or something called segmental colitis associated with diverticulitis, which tends to be in the elderly. And there's other mimics as well that are more common, like celiac disease or bowel syndrome. As a little curl from a primary care perspective, there was a meta-analysis in one of our large GI journals looking at a stool test called fecal calprotectin. I don't know if you guys are familiar with this, fecal calprotectin. Calprotectin is an enzyme that's released by neutrophils in the colon, or anywhere in the GI tract, and it gets released into the lumen and into the stool. So it's very specific for gut inflammation. So if you have a patient looking at, they pulled together studies taking patients with IBS symptoms, so abdominal pain, diarrhea, not necessarily not rectal bleeding, but sort of vague bloating, diarrhea, pain. When you look at those patients, if you check a stool calprotectin, that can be very helpful to help you risk stratify the patient. If it's negative, then it's essentially, the negative predictive value is very high. It's almost unheard of that they would have IBD. And if it's positive, then they may not necessarily have IBD, but there's probably something inflammatory going on, whether it's an infection, ischemia, other colitis. So checking fecal calprotectin, I think, would be very helpful in a primary care setting to help stratify. Say, okay, this person probably needs to go to GI quick sooner rather than later.
And that's a stool sample that they have to.
It's a stool sample.
And send out.
You can do it in-house or send out. And the key thing is to label it. The reason is diarrhea when you're sending it off, like is the indication of diagnosis associated with it. Because sometimes if you associate with other things like suspected Crohn's or ulcerative colitis, insurance companies may not pay for it. But when you put it as diarrhea, pay for it. So this is in one slide IBD therapy, because this is obviously a whole set of talks in itself. But I just want to frame this in terms of some of the next set of data I'm going to show you. So this is the therapeutic pyramid. So from bottom to top, from our least I'd say least powerful to most aggressive therapies. Where in the bottom here we have the salamine drugs, which are oral and topical agents that are typically our first-line drugs in ulcerative colitis. Still used frequently in Crohn's disease, but in Crohn's disease, actually, the data suggests that they do not work in Crohn's disease. But I'll show you some data in a minute that they actually are most commonly used. But still, this is the go-to first line for all IBD for most practitioners. Steroids, obviously, next step up. I would argue that steroids should probably be up here in terms of risk profile, but we see steroids commonly as well, using it as an induction. You get people feeling better quickly, and then try and figure out is there an exit, get them off of this quickly. But when we get them off of this, we're thinking one of these two types of classes. Immunomodulators, azathioprine, 6-MP, methotrexate for years are the go-to, which is your oral medications, or methotrexate can also be given subcutaneously. Lots of concerns about side effects. They take a little time to work, about 3 months. They still can be very effective seeing more and more of using them in combination with biologic agents as their best positioning. So the biologic agents are targeted monoclonal antibodies that have really revolutionized IBD care. The most prevalent one, the most around the longest, are the anti-TNF drugs. So this is the infliximab, Remicade, adalimumab, Humira, golimumab, Symphony, and these have been the real workhorses in IBD care for a long time. There's newer therapies now. In the last, since I started my training, there's three new pathways that we can target now. So for 20 years, we only had anti-TNF. Now we can target other pathways. So anti-integrin, which is blocking migration of white blood cells into the gut, and anti-IL-12/23, which is something called ustekinumab or Stelara, which is also used in psoriasis. And then the newest skeletal blocks are the JAK inhibitors. These are oral agents. Tofacitinib or Xeljanz. You guys probably have your rheumatoid arthritis patients on these. They're starting to use it now in ulcerative colitis. We're still trying to figure out where to place that. I think the risk profile of that drug is a little unclear to me. Is how safe it is because the pill is perceived as safer, where it may not actually. That's a whole other topic. So what are our goals of therapy? Once we get patients on therapy for many years, it's do they feel better? Right. So in ulcerative colitis and Crohn's disease, you're having no more diarrhea, no more bleeding, no more diarrhea, no more abdominal pain. Yes, great, move on, you're doing well, come back in a year, whatever. What we realize though is that in up to a third of patients, particularly in Crohn's disease, even though they're feeling better, they actually have a lot of ongoing inflammation still, objectively when you do a scope or imaging test. So this has moved the field in the last few years to say symptoms alone are not enough. You have to also look for objective measures of remission and response to therapy, ideally with endoscopy.
Can you use the calprotectin test to check for that?
So there's a lot of interest in that. There's a move now to include calprotectin in the next. So this I pulled from an expert consensus guideline on treatment targets. There's a push now for the next version of these to include calprotectin, because if you have a very, very low level, it has a good correlation with endoscopic remission. It's not perfect, but it's probably the AUC is like 0.9, so it's actually quite good. So now talk a little about how we now think of IBD as progressive disease. So for many years, this was the model of IBD. Over time, on the x-axis and inflammatory activity on the y-axis, flares of disease, and you get better, you flare, get better, flare, and get better. There's this cyclic pattern to your symptoms, and you would deal with this flare, and then the patient would go on their way and be doing just fine. What we realized that despite treating and conceiving of IBD in this manner, patients are still getting surgeries, still having complications. And so that led to a new conception of the treatment, change the treatment paradigm to starting to think of IBD as progressive disease. So not each one of these episodes of inflammation is so innocent. Each time you get an episode of inflammation, you can start to potentially accrue what we consider valve damage. So actually you can get longer term fibrosis, stiffness in the wall, development of fistula, development of strictures that are much harder to treat medically, and that over time each of these flares, inflammatory flares that we try to get under control with medicines, starts to accrue damage to the valve. And this leads to complications like abscesses, strictures, cancer in the worst sense, and also oftentimes even surgery.
Is there a sense of what contributes to those flares if people are consistent with their medical treatment?
So there's literature about adherence. Most of it has been with 5-ASA drugs, and patients who don't take them regularly are more likely to flare. Practically, there's a lot of issues we encounter with insurance, like having to go through prior authorization that leads to sort of a unintended adherence issue. And then we think a lot of it is that patients, there's some patients who will, their disease course will just be like this. We don't know why. And it's probably a combination of how they're treated early, what other events happen in follow-up in terms of dietary triggers. There's a lot of interest in dietary triggers, other medications they're exposed to as shifting the immune system to become a more aggressive phenotype. So there's what causes these triggers these flares is of great interest right now, and there's actually this longitudinal study of 5,000 patients in the UK going on, following people in remission, diet logs, stool tests, blood tests, other information about any kind of medications they're taking to see what are the common patterns high-risk cough flares. So like I said, over time, we're trying to prevent these complications. And at tertiary care center, this is usually where we see them. So, and we look, try to go back in time to get, what can we have done differently. But in Crohn's disease, strictures or narrowings that can lead to blockages, bowel obstructions, fistula, which leads to intra-abdominal abscesses, bowel dissections. Obviously, colon cancer is one of our feared complications, which is related to uncontrolled inflammation over time. And then in the worst cases, where there's lots of resections, people can end up with short bowel syndrome. And surgery rates over time in Crohn's disease, it's not all bleak, have gone down. This is a cohort study from from Denmark, where each of these lines is a different time period and surgery rates in Crohn's patients. So over time, this is from back in the 70s and 80s. So as we've gotten more immunosuppressive medications, biologic medications, the surgery rates have gone down. However, still 20% of people need a surgery by 5 years, and up to 10 to 15% of people may actually end up being a permanent osteoid over the long term. So we still have a long way to go to try to decrease the surgery rates. And similarly, in ulcerative colitis, the risk of needing a colectomy is probably 10 to 15% within the first 10 years of disease. Oftentimes, anecdotally, a lot of these patients will, this graph doesn't really capture this, but there's other data that usually within the first 5 years, patients will sort of declare themselves as a very aggressive phenotype, and will most likely get that surgery within the first 5 years. So the question is, can we start to change this trajectory of a progressive disease, accumulating bowel damage? Can we alter this history by controlling the inflammation early on, early intervention, and more effective therapies early in the disease course? In short, that pyramid I showed you before with 5-ASA, steroids, immunomodulator, so we need to be flipping that more to try to level this out so we have a flat disease trajectory. So what is the evidence in saying that it is important to actually use this early intervention approach and treat with more effective therapies earlier in disease course? Well, the first question is what do we consider early disease? Is it 5 years? Is it 2 days? Is it 6 months? This is an expert consensus, so take it with a grain of salt. I talked to the lead author. He said basically some people said 3 months, some people said 2 years. We kind of took an average and came to 18 months. But this is based on some of the data I'm about to show you, looking at kind of post hoc analyses of clinical trials and where the medications are most effective. But it is a little pulling out of thin air. So by convention, we kind of say within the first 2 years, we think this is that window of opportunity. But that is an area of research and interest, is what is that real window of opportunity when you have to, if you haven't changed the level of inflammation and gotten the person under control at this time point, you're already behind the 8 ball. Interestingly, in ulcerative colitis, there's no definition, and that is played out in a lot of the data on the show, is mostly in Crohn's disease, because in ulcerative colitis, there doesn't seem to be this window in the beginning. It doesn't seem to be as impactful as it is in Crohn's disease. We're not sure why. So first off, which medications are candidates for early intervention? 5-ASA, your kind of first-line drug, which a lot of people are comfortable using. They're low risk, relatively low efficacy in Crohn's. In UC, they actually work in a lot of UC patients. But in Crohn's disease, little to no utility. Steroids, obviously not a good long-term option. So the first medication sort of that's been looked at in this way are the immunomodulators, specifically azathioprine. And these are 2 studies in Europe where they randomized early patients, so in one case within 6 months, in the other case within 8 weeks of diagnosis, to either doing a more conventional step-up approach or getting placebo azathioprine and just watching them versus getting early azathioprine therapy. And basically, when they looked at rates of remission and relapse, which might not be the best markers because it's, like I said before, we're looking more at objective metrics, there's no difference. If these are not different, though, the objective metrics are not going to be different either. So in both cases, early azathioprine did not seem to change the trajectory of the disease within the first 2 to 3 years. So what about the biologic agents? So anti-TNF drugs, this is one of the first pieces of data that made people start to think, okay, maybe we should be using these a little bit sooner because the response rates are so markedly better in patients with early Crohn's disease. So this is certolizumab, which is an injectable anti-TNF drug where they first looked at the overall response rates at the end of this clinical trial. So this is about 12 months. 63 response rate. This is clinical remission, mind you. When they divided it up by disease duration, so long-standing disease, at least 5 years of disease duration, intermediate levels, and in less than 1 year, there were marked differences. Specifically, people in the first year having a 90% response rate. So it's got people thinking, oh, maybe if we use these earlier, they're going to be much more effective. So there's been a couple other post-hoc analyses like this, both in adults and pediatrics. We recently did a meta-analysis of these studies. So first we looked at the 4 adult trials and looked at disease duration in 3 pediatric trials. And when you look at the odds of being in clinical remission, so again, this is short-term clinical remission, usually 1 year. If you are a shorter disease duration, which is less than 2 years, about twice as likely to be in clinical remission in adults, and about 3 times as likely to be in remission in teens. So using these earlier in the disease course, you're more likely to be successful with your treatment outcomes. What about other mechanisms of drug, of biologics? So anti-TNF does seem to be a consistent trend. We did the first study in vedolizumab, which is an anti-integrin therapy. This is the first new mechanism after anti-TNF. So because azathioprine didn't work early, we had that hypothesis, well, maybe it's only an anti-TNF mechanism. But what we found, this is in an observational cohort, so there's obviously some caveats there, but an observational cohort of patients that were part of across multiple centers, patients with Crohn's disease less than 2 years, were more likely to achieve clinical remission, steroid-free remission, and also endoscopic remission, so that more objective measure over time. These are the Kaplan-Meier curves. And we looked at ulcerative colitis, there was no difference at all as well. So it seems like with both the anti-TNF and the anti-integrin therapies, there's definitely a more marked response rate and better rates of remission. What's attractive about vedolizumab is that the safety profile is probably the best of our drugs, so this is going to get a little more investigation. See if you can position this earlier, if you can get even more bang for your buck.
Can you elaborate a little bit more on that? And
Yeah.
the long-term side effects.
Sure, absolutely. So anti-TNF drugs, when patients Google anti-TNF drugs, the number 1, 2, 3 thing they come and talk to you about is cancer. And you say, this drug's giving me cancer, doc, I'm not going to take it. The main cancers that we're concerned about are skin cancers and with anti-TNFs, melanomas, and lymphomas is actually the one that seems to be most the more recent data is suggesting that a lot of that risk, at least for lymphoma, may be driven by the fact that a lot of those patients were also on concomitant azathioprine 6-MP or had prior exposure. And some data suggesting there's still a slight increased risk, but to put it in numbers, the relative risk increase is about 2 to 3, but an absolute risk for lymphoma is about 1 in 5,000 people per year will get lymphoma. If you're on a TNF drug, it maybe goes to 2 in 5,000 per year. So it's double, but you're going from a small number to another small number. This is usually the conversation on patients. The major thing is infection, and particularly upper respiratory infection, and flu, pneumonias. And so vaccination, that could be a little talk in itself, is preventative care in IBD. Because oftentimes patients see us as their primary care providers, and we have to also think about it when putting on these medications, a lot of vaccinations they need. And so the major risks are actually upper respiratory infections, including pneumonias. There's rare liver toxicities, the case report level. Most common extraintestinal thing, a non-infectious issue, is actually rashes. About 20% of patients on anti-TNF may get a psoriasis type rash. The major risk profile elements for anti-TNF that we always talk about patients. For vedolizumab, anti-integrin therapy is more gut specific. It's not as systemic of a drug. The main safety profile with this is actually nasopharyngitis, because the integrin that it blocking gut trafficking, white blood cells to the gut, is also expressed to a low degree in your nasopharynx. So patients are a little more likely to get a cold or sinusitis, but there does not seem to be. We just submitted a paper showing that there does not appear to be. It's in about 7 years of follow-up, so ideally 10, 20 years off, but there's not seem to be a signal for cancer with this drug, any type of cancer. And the infectious risk seems to be more mild or upper respiratory. So that's why the safety profile of this seems to be better than TNF. Even though we think the risk of uncontrolled disease is much worse than the low risk of side effects of these drugs.
I've had like 2 PEDS patients who actually developed antibodies to the drugs and just stopped working.
So that's a big issue. That's like a whole topic in itself where these drugs, because they're proteins, so it's like you can develop antibodies just like it was an immunization. So something that is a big area of interest and we're still trying to wrestle with. And if you talk to rheumatologists, they'll tell you that they don't do this because they have a lot of different drugs. We only have maybe 5 or 6 drugs. Rheumatologists have 15, 20. And we do what we call therapeutic drug monitoring. So we will check drug levels and antibodies. And where the timing of that is a big debate. But the antibodies is a real issue where you have a loss of response due to antibodies, probably about 10% per year at least. And so that's where you still will use some of the immunomodulators with these drugs to block the antibodies. And this is where lapses in treatment and adherence issues or insurance issues or lead to big gaps in treatment. You're more likely to develop antibodies in those situations as well, because it's like you're re-challenging the patient with the antigen after delayed. So it's unfortunately a common thing we see, and that we actually check in the clinic a little more frequently now to try to get ahead of that if we see antibodies starting. So a lot of the data I just showed you with early intervention is about earlier time points, 1 year, maybe 2 years of clinical endoscopic remission. But what about long-term outcomes? What about the rates of surgery, the complications? There's no data on that out there until recently. We did a study looking at what is the impact of actually achieving control of inflammation on long-term outcomes. Not just clinical remission, which is most of these studies that I showed you, but actually endoscopically, now you're normal, we got the inflammation control, what happens? So to do this, we actually took a landmark clinical trial that John Collenbell, who's one of my mentors, he's a big figure in IBD here. This recently was published in Lancet called the COM trial. Not to go into the details of this too much, but basically, these took early Crohn's disease patients who were biologic immunomodulator naive, the median disease duration of 3 months. So these are early diagnoses of Crohn's disease, naive to all therapies. And they randomized them basically to monitoring arms to just see how am I going to monitor your disease, just symptoms alone or symptoms plus objective metrics. And essentially everybody ended up on the anti-TNF drug during this trial. And they measured at 1 year endoscopic outcomes, clinical outcomes. And then what they found was that if you had a more aggressive approach to monitoring, where it wasn't just symptoms, but it was also looking at objective markers like fecal calprotectin or CRP in the blood, patients did much better. So 46% remission rate endoscopically, which is success, although to me this is also sobering that we have a long way to go in the field because you're taking the ideal patient population to respond to these drugs and you're treating them aggressively and still you're only at 46%. It's good, not great. But still, this was a very positive result because it was validating this treatment, this monitoring approach. And you're more likely to have endoscopic remission and deep remission. Deep remission meaning no symptoms, no steroids, and you're endoscopically in remission. So what we did is we looked at these two groups of patients and we recontacted all the centers to see, because most of these centers were in Europe, so patients tend to follow up just in the same center a little bit more in Europe. And so we looked retrospectively at all their charts to see over time, did any of them develop complications? And we stratified them by were they in remission at the end of COM, or did they still have active disease? And we had all the endoscopic scores and all of the clinical scores, et cetera. So we were able to divide them up into are you in remission or not at the end of 1 year of disease, what happens to you? So what we found was most of these patients had at least on average 3 years of follow-up, so long-term follow-up after this study. We were able to include just over half the patients in over 31 centers. A lot of patients didn't include were like Eastern Europe, and apparently they felt like they were fleeing the country or politically persecuted in those countries. Actually, unfortunately, there's a lot like Turkey, former Soviet bloc countries, and we saw about a 30%, just under 30% rate of events during follow-up. And when you look at a Kaplan-Meier curve for people in endoscopic remission over time, in the orange line here versus not in endoscopic remission, there was a significant difference in rates of disease progression, which we defined as combining any kind of new complication, including perianal disease, abscess, stricture, or needing a surgery or hospitalization. So if you are getting patients into remission early in their disease course, the chance that they're going to have a complication of the disease seems to be significantly less. And it's even more striking when you look at deep remission, where you have no endoscopic activity, no symptoms, and no steroids at the end of 1 year of treatment. Basically, 90% of people had no event during follow-up, whereas you have about half of people having an event during follow-up if they were still active at the end of 1 year of treatment. So we think this helps to another piece of data to support some of these tenets of early aggressive intervention and tight control and close monitoring. And when we looked at this in multivariable analysis as well, it's still held. So we've controlled for various other predictors of disease course, being more aggressive disease course. We saw that patients with deep remission had about 75% reduction in risk of disease progression. So it's pretty marked impact. There's still a lot of questions about early intervention. So what is it, like someone I mentioned before, what is this window of opportunity? How much does early treatment impact disease course? And we're going to have to figure out where we can position all the drugs in our tool chest. So just to go to the last topic, it's a little shorter. What are the obstacles for us actually getting patients off the therapy, getting them into remission? So delaying diagnosis, what are the current the right patients for this aggressive, more aggressive upfront treatment? So diagnostic delay is definitely a problem. The first data on this came from Switzerland, and this is a prospective cohort. They saw on median, on average, Crohn's patients between the time of symptom and diagnosis was 9 months, and UC was shorter, 4 months, which makes sense. It's coming with bloody diarrhea, you're more likely to get a scope quicker. And what's interesting with the account is that if you had a delay, particularly of greater than 2 years, you were twice as likely to develop a complication during follow-up. So diagnostic delay does matter because that bowel damage that I was showing in this graph before is probably starting to accumulate as soon as you start to get symptoms, maybe even pre-clinically. That's a whole other topic, but the longer you wait to get on the therapy, the more likely there are to develop complications. So we did a similar type of study like this in the US with one of our IBD fellows, and we figured because our healthcare system is more disjointed, the diagnostic delay probably be more marked. And so this was a online database that IBD patients actually called patient-powered web-based research cohort, where patients upload their data, clinical data, answer questionnaires. So it's cross-sectional, so take it with a little grain of salt. But most patients were reporting, particularly in Crohn's disease, delays of a year or greater than 2 years. So 70% of patients with Crohn's disease were saying that it was at least a year between their symptoms and when they were actually formally diagnosed. Lower in UC, which makes sense. And then over half of patients with Crohn's disease were saying they're having diagnostic delay greater than 2 years. So we asked them at what time, what were they perceiving as reasons for the delay? And basically they're blaming the GIs and the primary care docs, saying that we were giving them uncertain or wrong diagnoses. And other interesting things, I think, to be explored here are patients feeling that they didn't want this symptom to be explored further, or that they felt embarrassed by their symptoms. So I think there's a real obstacle here that we need to figure out how to get past in terms of going from symptom onset to diagnosis. And we saw a similar effect if you had a delay of greater than 2 years, odds ratio of 1.7 for having the disease complications of surgery, hospitalization. So in response to some of this data that was accumulating in Europe, a group in Italy developed what they call a red flag index for Crohn's disease. This ulcerative colitis present with bloody diarrhea, they can work out much more quickly, most likely. But in Crohn's disease, it would look like irritable bowel symptoms, for example. So it's a little tougher to tease out. And they basically built this score that's fairly complicated. But if you have a score where they weighted each of these elements, so non-healing perineal fistula, first degree relative of IBD, weight loss, abdominal pain, nocturnal diarrhea, fevers, pain not related to eating, rectal urgency. If you added up these weights, these weighted scores, you have a score of 8 or greater, that a predictive capacity with odds ratio of 2. I think it's probably some overfitting, but I think it's still a potentially useful tool that's being studied to see if you put it in practice, can you actually capture more IBD patients. And so what's going on in the real world? I mean, we preach this stuff at our academic centers, but when you look out in community practice, what are the rates of use of biologics in the first year of disease? So we think at least a quarter of patients with Crohn's disease are going to be destined to have surgery. And yet, despite that, the rates of biologic use are quite low. In the first year of disease, are only 5%. And this is from a health claims database that we did some research with. And when you look at a prospective inception cohort we have access to, and you look at patients who are moderately severely active, so clinically they're feeling horrible and are not doing well clinically, There's a little bit higher rate, but still low, 17% rate of prescription among the higher, the more active patients. And this is another way to visualize what's going on in real world practice. This is something called Sankey diagrams, which are used in both fluid dynamics and topography. So kind of they use it to show how fluid in, say, a piping system was flowing through a set of a building or a set of piping system. Engineering made by engineers. So basically, what they did was they used a national database, the Truman Market Scan database, which you're familiar with, and they looked at what they thought were incident cases of Crohn's disease, and then followed them over time. And the most common treatment patterns were either corticosteroids alone, just getting cycles of steroids, or 5-ASAs alone, which we don't think work in Crohn's disease. There's lots of evidence out there that does. And then you look at biologic use and other immunosuppressants, like 3%, 1%, and basically less than 5% run of biologic early, and over time, maybe you get up to about maybe 10% at most. So in the real world, this is the common thing we see: 2, 3, 5 years, often on steroids, maybe on some potassium with Crohn's disease, and they come to our ER with an abscess and need surgery. Similarly, ulcerative colitis. I think it's not as big an issue in ulcerative colitis because 5-ASAs are effective, but you also see low biologic use, which seems probably more than 0%. It's not exactly 0%. It should be on biologic related disease scores. So the big question here, though, is, as we were talking about before, not all these patients are destined to an aggressive disease course. So how do you select the patients that you're going to introduce these drugs earlier on? And so this is a slide that we use a lot, where how do I find this person who is going to have an indolent course versus the person who's aggressive disease, and at the time of being the patient, they may look very similar, symptoms-wise, laboratory-wise, etc. So there's been a push in the field now to try to develop better tools to risk stratify patients earlier on around the time of diagnosis, and thinking about how do we select our therapy, not just based on the symptoms, but based on the predicted trajectory for the patient. So in the most recent care pathways for Crohn's disease and ulcerative colitis by our national association, they actually started to get this idea in there. Although we don't know how to weight any of these, or we don't know if you have 2 of these factors, or 3 of these factors, all of these factors, does that mean you're going to have an aggressive disease course or not? But they're trying to get people to start to think about a low-risk patient for surgery complications and a high-risk patient for surgery complications. And the most elegant example of this, it's still not ready for prime time, it's not in the clinic yet, is something called the Prospect tool. So this is a tool developed by Corey Siegel at Dartmouth, where enter information about where the disease is located, patient's age, how long they've been diagnosed for, and some blood markers and genetic markers that have been associated with more aggressive disease course. So the serology is called ASCA, and a genetic test called NOD2. This is a gene that's highly associated with Crohn's disease, but also with the more aggressive disease course. And by putting this information into this dashboard, they generate a personalized risk profile for patients. So within the first 3 years of disease, what's their risk of developing complications? So basically, stricture, fistula, needing a surgery. And they develop, they actually put the patient's name up here. They have all the interactive display where you can either toggle this to percentage risk or just low, medium, high risk. Apparently they did focus groups. Patients just want to know by low, medium, or high as opposed to a specific number. But then you can kind of show a patient, you tend to be, looks like you're going to have a more indolent, less aggressive disease course. Maybe we can just monitor you, change your diet a little bit, and just closely watch you, versus someone who's destined to higher risk progression of disease. Right.
Yeah. Are the insurers going to pay for early initiation of the biologics?
So it's a good question. So right now, we've not encountered too many obstacles to it yet. Usually,
so they're not making you go through 5-ASA first, or
it depends on the insurance company. A lot of it, almost always when we order a biologic, the insurance company comes back to us and says, "Have they failed X, Y, Z?" Yeah, right. And usually they've at least been on a steroid. And even if they haven't been, we then will write back to them with, "These are the high-risk features. We don't want to wait. They can't tolerate steroids for X reason." We basically say whatever we need to say to try to get them on the biologic, or to get them onto whatever therapy we think most effective. To be honest. Yeah. And so, but usually the knee-jerk reaction is to ask us to send them more information, prior authorization, and we're fortunate to have staff in the IBD center that will fight the insurance companies about this. And I think that's another reason for some of the real-world data where it's easy to write a script for steroids and 5-ASA, and if you have a private practitioner, maybe 1-2 person practice, literally it could be an hour or two or more of paperwork on the phone and all this nonsense. So there's actually the National GI Society has Advocacy Day. This is Colorectal Cancer Awareness Month. So along with colorectal cancer initiatives on Capitol Hill, they're also talking about step therapy within certain. It depends on the insurance company, but a lot of insurance companies still have that prescribed. But if you push back, they usually don't. But they don't. You don't want to even have that first hurdle. So that's the future. This is not yet there, but it'd be great if we could have a patient. I could show them this risk profile, come to a decision about, okay, do you need? I think you do need a biologic early or not. In a more shared decision-making approach, this kind of tool can really help that discussion. And so lastly, a program we have at the IBD Center here that we've been doing for about a year now, called COMPASS-IBD, Comprehensive Care for Recently Diagnosed IBD Patients. We have a little logo that my sister actually made. She's actually pretty good. So this is our program that is trying to bring a multidisciplinary approach to patient care from the get-go. You probably have heard, I think there's medical homes within IMA. At IBD Center, we have a medical home as well. And in general, those tend to be identified patients who are already high utilizers, already high-risk patients, lots of comorbidities. So our thought process was, well, what if we could identify those patients early / offer these services early before they become a high utilizer? Could that help change the course? Still in infancy of this program, but that's the kind of the vision of it. Offer these services early on before you wait for them to declare themselves as a high-risk patient. So this is where we're located in this building right now. This is the most beautiful picture of this building. There's no like, there's not like 3 vans parked out here, people yelling at each other here. So we're on the 5th floor, so it's just across the way over here, and they have the whole floor there. And so, like I mentioned, this is to rapidly connect recently diagnosed patients with a tertiary multidisciplinary care model. Patients are eligible if they've been diagnosed in the last 18 months, or patients who have a high suspicion of new onset IBD, and basically we try to get them in within 2 weeks of referral. So when they come, they spend a morning with us, and we do obviously an IBD consultation. Oftentimes they have a primary GI already. It's that side of usually getting very good GI care for their IBD. So it becomes more of a discussion about their risk stratification and disease education around medications and what's the risk over time of developing a complication. Then they meet with our nutritionist and get a full dietary evaluation. Then they meet with our health therapist, either a psychologist or a social worker, who does a lot of counseling around stress and anxiety. I always tell patients who live in New York City, so if you're not stressed and anxious, something's wrong with you. I'm actually more aware. So this is trying to develop what we call resilience. Our psychologist, Lori Kiefer, is really pioneering this field and trying to help patients develop that grit to like bounce back from adversity and really kind of take a negative into a positive. And so a lot of coaching around that. They meet with our pharmacist, who does a lot of detailed explanation of logistics and helps with navigating getting these patients onto medications that they need, and also does preventive health, reviewing their immunization status and recommending immunizations. And then at the end of it, we developed a personalized care plan where we basically, it's a document where we summarize everyone's recommendations, as well as some basic information about their disease, and we give it to the patient and to their primary provider. And through this process, we identify patients who need more navigating of their insurance company and getting their medications, or need more dietary nutrition advice and more intensive follow-up with that. And so then we link them into these programs that are part of the medical home early on. This is the whole team. Let's see, I'm the only Y chromosome. And yes, it's really it's a great multidisciplinary team. And I must say, working with the nutritionist and the health therapist and the pharmacist, they find things that you would never think of, or either don't have time to ask about or don't think to ask about. For example, we're finding a lot of vitamin C deficiency in our IBD patients actually. And when she asked, actually had like some subclinical symptoms of scurvy. And so that we never would that was just for all our nutritionists was pulling that for us. So it's really a rewarding experience working with this whole team. And this is already I already kind of mentioned, this is sort of the sample schedule where patients come in, they do our nurses, and then set them up to meet with me, our nutritionist, our health therapist, and our clinical pharmacologist. And then we follow up with them with the care plan. So that's our program. Like I said, we've only been doing this for about a year. So about 60 patients who've gone through it. So when we first started this program, we don't have any recently diagnosed patients here, but we do. We actually see probably about anywhere from 3 to 5 a month. And right now we're only seeing internally, so we're trying to figure out a way to reach out to community practices to try to make this service available for community practitioners. But just some takeaway here is on the small end, but the vast majority of patients thought it was excellent services, and everyone thought that they would say they recommend this program to a friend that they had IBD. When we looked at patients that we thought should be on a biologic, we compared them to other recently diagnosed patients in our IBD center. We also thought would probably be on a biologic. We said, okay, within 3 months of their first visit with us, what percentage were getting onto a biologic within 3 months? And it was a significantly higher percentage who did our program versus not. Odds ratio of 4. I think that is probably 2 things. One is they get linked in with our clinical pharmacist, so I think helps navigate any kind of roadblocks, logistic roadblocks. But 2, I think when patients, you acknowledge them, there's aspects of your disease that I, as the doctor, can't necessarily take care of as well, like your diet, your psychosocial health, etc. And you give them those services, I think you get a lot more buy-in on what you're trying to accomplish with an overall medical plan. And then these patients also stay more engaged. We see that they're coming back for twice as many visits in the next 6 months than the patients who didn't do this program. And it's mostly driven by they're now linked in with our ancillary staff, our complementary services. And then lastly, something that we just built, and I'm curious as feedback, is an e-consult. I don't know if you guys use e-consult, the feedback, e-consults are sort of a thing inside. So the e-consult for suspected IBD. This is probably, it's a little tricky because I think there's also a general GI consult as well. But if there's somebody that was recently diagnosed with IBD, or you think does have IBD, you can now put in .e-consult IBD. It'll self-populate the vast majority of the information, and then it brings to the prompts on that red flag list that I had up before. So it's about 8 questions that you can just click through, yes, no, yes, no, yes, no, yes, no. And then it would send the consult to me to say, oh, this sounds like we need to do IBD, then we'll get them into the IBD center, or actually maybe go to general GI first, or do this next, and including maybe check CalPro, for example. So this is something that probably do some more advertising of. I think it may be of use. I don't know how much people use this or not. So yeah, that's it. Just to thank my mentors and collaborators and co-faculty. I just found I got my K23, so I was excited about that. I was it yesterday. And other research funding. So thanks for your attention. And any questions? Yeah.
The question here that identified is the risk versus critical biopsy. Is that tested in a primary care setting or is it tested in a specialist setting?
So they use it in an Italian internal medicine practice. So they did. The paper doesn't say exactly, because internal medicine in other countries means different things. So I presumed it was a primary care setting, but there may have been a mixture of other GI patients in there. And the way they first did it is they looked at diagnosed patients with IBD, and they looked back at their first encounter, whether it was a GI or primary care. And they did a second cohort, which was an internal medicine practice that to try it out.
So it sounds like it's the best we have, but it's not going to be tested in the right setting.
Exactly.
So we're going to ask Rosie one more question, and then if you guys have more questions, feel free to come off.
Yeah.
Between the dietary factors, is there any role for like high doses of natural anti-inflammatory compounds or something like that?
Yeah. Yeah, this is a question that goes a lot. That's actually the most common question I probably get from patients, like, what should I eat? So right now, there's not any clear role for specific nutritional therapy. But I think it's wrong to tell patients, I think sometimes in the past, people will tell patients, they'll come to us and say, my doctor said diet doesn't matter. I think it's probably wrong to say that, because I do think this diet, even whether it's not, we don't know if it's impacting inflammation or not, it's certainly impacting symptoms. And there's a trial going on right now that everyone's eagerly awaiting. It's randomizing people to 2 different diets. One is just the Mediterranean diet, which is a controlled diet. And the second one is something called the specific carbohydrate-free diet, which is a It's been in vogue in this Crohn's disease community as a alternative therapy for many years. Basically eliminates a lot of processed sugars, processed carbohydrates, and so they're putting randomized people into both of those diets and seeing what happens. Results both objective and subjective. So that'll be the first dietary intervention trial in IBD, which will hold that as add more guidance. There's some smaller observational studies and some basic science data that take with a grain of salt. The most interesting thing that I've seen is something about emulsifiers, which are the chemicals that are put into very highly processed, long shelf life foods. The best example is peanut butter, where you have that natural layer of oil and natural peanut butter, but then Jif and Skippy on the shelf is like perfectly homogenized. That's homogenized by a chemical called emulsifiers. And in mouse models, so take it with a grain of salt, mouse models of colitis, mice genetically predisposed, you give them emulsifiers, they develop rip-roaring colitis, and it like strips away the lining, the mucus layer on top of on the inner lining of the colon, and allows bacteria to more directly interact with the immune system. So take it with a grain of salt, but I think it's in general probably a good piece of dietary advice. I usually tell less processed foods. So it's really hard to study diet. It's a big problem, but it's an issue we encounter because there's a lot of people out there like on the internet saying do this specific diet or not.
Well, thank you again.
Well, thanks.